Hello, this is Eric Strong, and today I will be discussing inpatient diabetes management. The learning objectives will be to understand the goals and challenges of inpatient diabetes management, to be able to create an initial treatment regimen for a diabetic patient admitted to the hospital, and to be familiar with basic principles of adjusting an insulin regimen in response to persistent hyperglycemia or NPO status, that is, nothing by mouth. Be aware that the management of diabetes is an extremely detailed and nuanced topic, and this video will just be providing a general overview. Always consult an experienced healthcare professional when making any adjustments to a diabetic treatment regimen. The goals of inpatient diabetes management are first and foremost to avoid hypoglycemia, which in the short term is much more dangerous than hyperglycemia. Second, to avoid hyperglycemia. Next, to assess outpatient glycemic control and consider adjustments in consultation with outpatient providers. And finally, to assess the need for diabetes education, which can be performed in the hospital while the patient is a captive audience with plenty of time. The inpatient management of diabetes can be very challenging due to a large number of factors which can disrupt the metabolic processes keeping a patient in euglycemia, balanced between hyper and hypoglycemia. One of the major factors that contributes to hyperglycemia are many hormones and other mediators that are increased during acute illness. These include cortisol, catecholamines like epinephrine, glucagon, and various pro-inflammatory cytokines. Others are the use of IV dextrose, along with carbohydrate-rich enteral and parenteral nutrition. Hyperglycemia can also be exacerbated by the use of exogenous steroids, which can be part of the treatment of a number of conditions such as a COPD exacerbation or elevated intracranial pressure. And finally, there may be new contraindications to a patient's previous outpatient oral medications. For example, acute kidney injury and NPO status are contraindications to sulfonylureas. Volume overload is a contraindication to thiazolidinediones, more commonly known as TZDs or glitazones. And kidney injury and recent or anticipated iodinated IV contrast are contraindications to metformin. In addition to the contributing factors to hyperglycemia, factors contributing to hypoglycemia include poor or unpredictable PO intake while a patient is acutely ill. Also, outpatient non-adherence can be problematic as well if a patient appears to be well controlled when he or she is secretly only taking medication some of the time or only taking some of the medications the medical staff believes he or she is taking. The consequences of hyper and hypoglycemia can be severe. Hyperglycemia can lead to an osmotic diuresis and volume depletion, electrolyte loss, and general immune dysregulation, while hypoglycemia can lead to altered mental status, seizures, and if not immediately corrected, permanent CNS injury. Another factor that complicates inpatient diabetes management is the uncertainty regarding what the appropriate glycemic target should be. With the passage of time and accumulation of more scientific data, opinion on appropriate target glucose levels has changed. Up until about 10 years ago, the prevailing opinion had been that providers should be attempting to get all diabetic patients to euglycemia while in the hospital. However, newer and larger trials in a variety of patient populations have demonstrated either no benefit to tight glucose control, or in some cases, even worse outcomes with tight control. Thus, in 2009, a joint task force with representatives from the American Association of Clinical Endocrinologists and the American Diabetes Association released a consensus statement in which they recommended a target glucose in most ICU patients of 140 to 180 milligrams per deciliter. In non-ICU patients, they recommended a target preprandial glucose of 100 to 140 and a target random glucose of 100 to 180. There remains small subsets of ICU patients who may benefit from tighter control than 140 to 180, such as post-cardiac surgery patients. Keep in mind that these are only guidelines and that, in practice, targets should be individualized to the patient and to the situation. One situation in which this is definitely true is for patients nearing the end of life where a target glucose range might be whatever keeps the patient asymptomatic. A provider might tolerate glucoses up in the 300s or even higher without intervention in this specific circumstance, depending upon the patient's goals of care. To understand how to decide upon a diabetes regimen for an inpatient, I will first need to briefly review the different categories of insulin. Categorized by Pharmacokinetics, there are 4 general types of insulin. First is the very short-acting insulin, into which Lispro and Aspart are placed. These have a very quick onset of action of 5 to 15 minutes, have a peak effect at 45 to 75 minutes, and last a total of 2 to 4 hours. So-called regular insulin is considered short-acting, takes effect at 30 minutes, peaking at 2 to 4 hours and lasting 5 to 8. NPH is an intermediate-acting form of insulin with an onset of 2 hours, peak at 4 to 12 hours, and duration of 18 to 28 hours. Finally, long-acting insulin, which includes glargine along with some less common others, also has an onset of 2 hours, has no particular peak time of action, and lasts more than a day. Insulin can also be categorized based on function. That is, what role does a particular form of insulin play in a patient's management strategy? For example, there is basal insulin. The function of basal insulin is to cover the body's insulin needs to maintain basal metabolic activity. That is, it reflects the fact that our bodies need insulin even when we are not eating or doing much of anything. Common regimens of basal insulin are glargine every 24 hours, usually at bedtime, or NPH every 12 hours. In critically ill patients, a continuous IV infusion of regular insulin can also be used for this purpose. Next is prandial insulin, sometimes referred to as bolus or nutritional insulin. This prevents the hyperglycemia that would otherwise occur as a consequence of eating a meal. In patients who are eating, common regimens include regular, Aspart, or Lispro before each meal. In patients who are NPO, this should obviously be held. Finally, there is corrective insulin, which is more commonly referred to as the sliding scale. The sliding scale is intended to correct hyperglycemia that is already present before the meal starts. This can be done with regular Aspart or Lispro, given before each meal and at bedtime in patients eating, and given every 6 hours in patients who are not eating. The insulin sliding scale itself can be a little confusing at first. Each hospital typically has its own scale, pre-approved by a committee of pharmacists and physicians. Here is just one example of such. The only decisions the ordering physician needs to make for an individual patient is which form of insulin to use and which of the 3 levels to use. The mild scale is generally reserved for insulin-sensitive patients, such as type 1 diabetics. The moderate scale is used for most type 2 diabetics. And the aggressive scale is for patients with unusually high levels of insulin resistance, which are a minority of type 2 diabetics. So how do we use this information about insulin to choose a treatment strategy in a specific patient? When a diabetic patient is to be admitted to the hospital, the first question to ask is, does the patient have an indication for a continuous infusion of insulin? Well agreed upon indications include septic shock, post-cardiac surgery, moderate to severe diabetic ketoacidosis, and the hyperosmolar hyperglycemic syndrome. Some clinicians prefer to use an insulin infusion in any diabetic who is critically ill. Insulin infusions are a complicated topic, the details of which are beyond the scope of this discussion, but most hospitals have well-established protocols in place, so few decisions are needed of the provider once the decision to use the infusion itself has been made. In patients who do not have an indication for continuous infusion, ask whether the patient meets all of the following. Is he or she a type 2 diabetic? Is his or her diabetes well controlled as an outpatient with diet and or oral medications? Is it anticipated that the patient will be eating normally and there are no contraindications to his or her regular outpatient oral medications? If all these criteria are met then the most appropriate treatment strategy is to continue the outpatient regimen and add a 4 times a day finger stick, that is, a bedside glucose check, along with a sliding scale. If the patient is on a sulfonylurea, such as glipizide or glyburide, the provider should consider a modest dose reduction, as these meds can lead to hypoglycemia if the patient's PO intake is not equal to that as an outpatient, which is common in the hospital. If, on the other hand, the patient is well controlled as an outpatient with insulin, including those on an insulin pump, and you anticipate that they will be eating normally, then continue the outpatient regimen plus the finger sticks and sliding scale. As with sulfonylureas, consider a modest dose reduction in either the basal and or the bolus insulin dose. What if the patient does not fit into any of these three categories? Everyone else, which actually ends up being the majority of patients, should be placed on what is known as a Basal-Bolus Regimen. Creating the Basal-Bolus Regimen is a multi-step process that begins with estimating the total daily insulin requirement, abbreviated TDD for total daily dose. There are several very simple equations described in the literature to do this, some of which are more conservative or liberal with insulin than others. The following is a rough average of the different approaches that are out there. For most type 2 diabetics, the estimated total daily dose is about 0.4 units per kilogram of body weight. In type 1 diabetics, the elderly, and in patients with renal insufficiency, using a value of 0.3 units per kilogram is safer with less risk of hypoglycemia. 50% of this total daily dose will be devoted to basal insulin, which can either be further divided into twice daily NPH or as once daily glargine or other long-acting insulin. I usually prefer using NPH for hospitalized patients who aren't already on glargine, because NPH can be titrated more rapidly in response to changing insulin needs as an acutely ill patient. However, some clinicians are reasonably concerned that NPH can lead to unphysiologic peaks and valleys in blood glucose that can actually make inpatient titration even more challenging. The other 50% of the total daily dose will be for bolus insulin, divided into 3 equal doses for each meal. Regular aspart or lispro insulin can be used, with regular given 30 minutes prior to the meal and others given immediately prior. Finally, although not part of the total daily dose distribution, patients should also be placed on a corrective sliding scale using the same form of insulin as used in the bolus dosing. Given the concern over in-hospital hypoglycemia, whenever rounding a dose of insulin, one should always round downwards. Now, how should the provider adjust insulin in response to suboptimal glycemic control? First, the regimen should be reassessed every 1 to 2 days, with glargine adjusted no more frequently than once every 2 days. One should generally not react to a single high reading if others are within the target range. However, even a single hypoglycemic episode should prompt an adjustment. What are the specifics for up-titration of insulin in persistent hyperglycemia? If the glucose levels are above target at all times of the day, one should increase the basal insulin. If the glucose is above target only at certain times of the day, adjust according to this chart. If the AM fasting glucose is high, one should increase the PM basal dose of NPH. If the pre-lunch glucose is high, one should increase the AM bolus of insulin. If the pre-dinner is too high, increase the AM basal. And if the bedtime glucose is too high, one should increase the PM bolus dose. For patients on glargine who only have a consistently elevated glucose in the morning or before dinner, or some other very specific time, some creativity may be required, as glargine does not have peaks and valleys of activity like other forms of insulin do. For example, imagine a patient on glargine for basal insulin and lispro for bolus insulin, whose glucoses are all fine except for persistently elevated pre-dinner glucoses in the 300s. The provider may need to increase the glargine dose, but in order to decrease the risk that hypoglycemia will develop at other times of the day, he or she may need to simultaneously decrease all of the bolus doses such that the total daily dose of insulin is increased very modestly. If glucose elevations are at random times with no discernible pattern, things to ask include: is the patient on a consistent carb diet? Is the patient eating each meal consistently? And is the patient sneaking carbohydrate-rich snacks? That's a good lead-in to discuss proper nutrition for diabetics. This is another huge topic, but let me discuss it in extreme brief. The previously popular term for the inpatient diabetic diet, the so-called ADA diet, never really meant anything specific, and at many institutions this referred to a calorie-controlled diet low in simple carbohydrates without necessarily paying close attention to consistency in total carb content each day. For patients taking oral nutrition, the recommended diet is now the consistent carb diet. The components of this diet include equal total grams of carbohydrate each day, equal grams of carbohydrate in the same meal from one day to the next, approximately equal grams of carbohydrate each meal compared to others in the same day. There is no specific calorie level, and surprisingly, it does not necessarily restrict the use of sucrose, provided it's done in small amounts and in a consistent manner. How does the typical basal-bolus regimen change if the patient is NPO? First, consider a dose reduction in basal insulin. Type 2 diabetics on NPH should have a closer to 50% reduction, while in type 1 diabetics and type 2 diabetics on glargine, a reduction of 25% is more appropriate. Next, eliminate the bolus insulin. Finally, keep the sliding scale there, but change the regimen from before each meal and at bedtime to every 6 hours. And in addition, the sliding scale should generally be downgraded. For example, an aggressive sliding scale should be switched to moderate, and a moderate sliding scale should be switched to mild. Finally, there are some considerations before discharging a diabetic patient from the hospital. Should the hemoglobin A1C be checked? Should the patient's outpatient regimen be adjusted? The decision to adjust should be based on the hemoglobin A1C and not based on inpatient glycemic control. Generally, avoid changing the outpatient regimen if the A1C is less than 8%, unless there is a new contraindication to a previously used medication. And only adjust the outpatient regimen in consultation with the patient's outpatient provider. Finally, does the patient need diabetes education? 3 common misconceptions about inpatient diabetes management, which I've already gone over but would like to just highlight here towards the end. Oral hypoglycemic drugs should never be used as an inpatient. The sliding scale as the sole means of glucose control is appropriate for most patients. And patients who are NPO do not need insulin. All of these statements are completely false. Let me conclude this lecture by working through a multi-step example. A 68-year-old man with type 2 diabetes on metformin and glyburide as an outpatient is admitted to the hospital with pneumonia. A recent hemoglobin A1C was 9.3%. The patient is 105 kilograms in weight. What is an appropriate diabetic regimen for him at this time? Step 1. Decide if this patient is appropriate for an insulin infusion or for orals. In this case, he has no indication for an insulin infusion per se, and his poor outpatient control indicates that oral medication is not appropriate. Step 2. Estimate the total daily dose of insulin. This is 0.4 times his weight in kilograms, which in this case is 42 units. Step 3. Calculate the basal dose as 1/2 the total daily dose, which is 21 units. This can be provided as 10 units NPH twice a day, or alternatively as 20 units glargine once a day, usually done at bedtime. Step 4. Calculate the bolus dose, also 21 units, which is then divided into 3 equal parts. Rounding down for convenience and safety, this becomes 5 units of regular insulin 3 times a day before meals. Step 5. Don't forget to include corrective insulin. So in summary, an appropriate initial regimen for this patient would be NPH 10 units sub-Q BID AC, which is medical shorthand for twice a day before breakfast and dinner. A perfectly fine alternative would be glargine 20 units sub-Q QHS, which is shorthand for bedtime. Regular insulin 5 units sub-Q TID AC, that's 3 times a day before each meal. And finally, a regular insulin sliding scale. I would choose a moderate scale as the patient is type 2 and without evidence of unusually high insulin resistance. Here are the patient's blood sugars after the first 48 hours in the hospital. His oral intake has been poor, but consistent. What, if any, changes are appropriate to his insulin regimen? You can see that all of the blood sugars are within goal, or close to goal, with the exception of 2 pre-dinner measurements, both of which are above 300. Therefore, the appropriate change to make would be to increase the AM NPH dose. There is no magic formula for how much to increase it, other than avoiding any changes that are too drastic. Therefore, the only change would be an increase in the AM NPH dose from 10 to 15 units. Continuing on, his blood sugars are subsequently well controlled, but due to the non-resolving nature of his pneumonia, a bronchoscopy is planned for the following afternoon, and the pulmonologist requests that he be made NPO from midnight. How should this regimen be changed? Here's the current regimen again. While NPO, remember that the patient should have the basal insulin reduced by 25 to 50%, the bolus insulin should be DC'd, and the sliding scale should generally be downgraded. Therefore, the patient's regimen while NPO should be NPH 7 units each morning before breakfast and 5 units each evening before dinner, with a mild regular insulin sliding scale. That concludes this summary of inpatient diabetes management. If you found it interesting, please remember to like or comment on the video, and please subscribe if you are interested in additional lectures on a variety of inpatient medical topics.